I'm asking for assistance to show you how do doors open? How do doors open?
By the grace of God.
What do you have to do to get a door to open? So you're saying doors open because of pressure on one side, not the same pressure on the other side. Is that what you're saying to me?
Yes.
Okay, they themselves don't contract or open. I mean, we don't have automatic doors. There are some like that, of course, but we're not playing with that. So, Ray, I'm going to leave the classroom, okay? And you are going to try and get out of the classroom. So when I say 1, 2, 3, you start trying to get out, Are you okay? Or do you have to work? Do you have to work? Okay. So clearly the door did not open the way it should have, right? Okay. Blood will only flow from high pressure to low. That door will only open if there's a higher pressure. Now, if all 10 of you got on there and was pushing, you'd outmatch me, right? Of course. And then you could flow out. Of course you could. So I need you to keep that in mind. That door does not open on its own. You exert a pressure difference, and then it swings open, and then you can move. Right? You can apply that to every day. Every day. So the AV bundle is this part right here going through the atrioventricular septum. Fibrous material, not a good conductor of electricity. And then we see a bifurcation, a splitting. And those are called the right and left bundle branches. Remember, it's the patient's right and the patient's left. And then it moves around these specialized cells, not moves, but they arch around the ventricular walls. And over here, these are large, large cells. And they have a lot of intercalated discs. And these are called Purkinje fibers. And they allow the action potential to spread very, very quickly. So delay here, but then we gain momentum. Are you okay with that? Well, too bad we're going to do it again. So the SA node is the pacemaker. It reaches action potential threshold first. I'm going to show you why, and we're going to draw it out on the board. From there, it spreads through internodal pathways down and to the left. These pathways go from the right atrium to the left atrium and down to the AV node. Once we get to the AV node, there is a delay. Do not memorize how many milliseconds there are in this delay. Just know that there is a delay here. Why? There are few cells and very few intercalated discs. We are going to see another delay in the AV bundle, or bundle of His. Do not memorize how much of a delay. I need you to know that there is a delay in these two places. And that is enough for the atria to have their turn, and then the ventricles get their turn. Otherwise, blood is not going anywhere. You just saw Ray not able to get through that door, correct? Timing is everything. So the bundles, right bundle branch, left bundle branch, come off of the atrioventricular bundle. Again, that is one of our two delays. And the right bundle branch and left bundle branch are going to conduct, the action potential through the IV septum and around the apex to the ventricular walls. Now eventually, and I did clarify, they don't have EKGs here. If they did, I would have definitely taught you why the EKG looks the way that it does. And if we ever have some time left over and you want to learn why, I will teach you, which means when you take an EKG class for your future healthcare careers, you will know exactly why the pen goes up and the pen goes down, and why exactly the pen can flatline. And Grace is in the back. She's probably like, I look at this all day long. But this is not to dismiss, but did you learn vector analysis when you learned about EKGs?
I know about EKGs because I take them on patients.
I know you do.
What the EKG can tell you is if the AV node is malfunctioning, if there's a blockage in the AV node to what's the second one down there?
Bundle of His to the right and left bundle branch.
There's a blockage going into when it branches out. If your Purkinje fibers are overly reactive, and or if across the one that goes across at the top,
the internodal pathways.
yeah, if that one also, there's a problem with that. So it's like, and you can see it all in the EKG.
Grace is 100% correct. You can see it on the EKG. It is a picture. And you've seen enough of them where you recognize the pictures.
Yeah, where it's happening.
You do. And there are reasons why you get the picture that you see. So there are physical events where if you understand the vectors that are occurring, then it makes memorizing these pictures less tedious.
At first it's really hard to grasp it until you actually see it.
Sure.
And even then, a lot of people really are really confused with cardiac events, whether what is an actual heart attack, when it's a blockage, or if it's an electrical combustion problem because of electrolytes. There's like two types of cardiac events that happen, and they all confuse it into like a heart attack is just a heart attack. It's really two things. So people that are actually really healthy can have a heart attack.
Sure.
Not because there's a blockage or atherosclerosis in your arteries, but because of electrolyte imbalance. So here in the valley, people need to be very careful about their electrolytes and being hydrated, especially if any of you do sports. Because that's how young people have actual cardiac events or cardiac arrest.
So again, if you ever want to know more, you're 100% correct. If you ever want to know the difference between ischemic issues versus electrolyte, but there's also voltage-gated channelopathies.
Yes.
And that is not necessarily an electrolyte disorder, but it is a problem with certain voltage-gated channels opening and closing appropriately. You've heard of children being found dead in their beds, right? You've heard of that. They have a channelopathy where, think about it, when your alarm goes off in the morning, how do you feel? Alarmed. Of course you do. You're like, I gotta get up. And back in my day, we actually had clock radios, and you could turn on music, but it also would go, wah, 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 wah. And you hear that even on commercials to this day that show that. I'm like, and it makes my heart start going. And during the break, I'll show you a cute video regarding that. But you are 100% correct. So eventually there will be time, if you ever want me to go through that and teach you the molecular reason to back up the clinical application. I'm ready to do that, and I can do that, okay? But you are 100% right, Grace. You are 100%. I'm just going to augment what she said. She is not wrong at all. Clearly a professional. Purkinje system, a lot of intercalated discs, and they are larger fibers. So we pick up conduction, speed, velocity. So how can specialized cells spike an action potential on their own? And there are a couple things that I want to draw your attention to. And because I know that it's on the board, I can draw it here. I'll remind you that in a typical neuron, this is pretty much what your action potential looks like. There's threshold, then we have the spike, the upstroke, the downstroke, where we have hyperpolarization. I'm just going to put hyperpol. And then we go back to resting membrane potential. Specialized cells do not have a resting membrane potential. Nowhere on this picture do you see a flat line where they have resting membrane potential. They are constantly migrating towards threshold. And this ramp, if you will, is called the pre-potential. Now, I need you to go back and think from last semester, how can we make the inside of a cell less negative, more positive? Do you remember your electrolytes that Grace was just talking about? I asked you to know about sodium, calcium, chloride, potassium. I asked you to know about the big four. So how can we make the inside of the cell less negative? We can let positive charges in, can't we? We also have the choice of blocking more positive charges to stay in the cell. I'll remind you from last semester, the big three reasons why the inside of the cell is negative. Negatively charged proteins, the sodium, potassium, ATPase, but most importantly, the potassium leak channels. So if we block those potassium leak channels, the more potassium stays inside the cell. That's a positive charge. And the inside of the cell will get progressively more positive, less negative. We also can open some sodium channels as well. So feel free to ooh and ah, because this took me a long time to do. We can let sodium in, and the inside of the cell will get more positive. You see my little black arrow on the pre-potential? More sodium comes in. The inside of the cell becomes progressively more positive. More sodium comes in. And finally, we reach threshold. And then we have our action potential. Our usual suspects. Sodium voltage gated channels opening more, and then for repolarization we have potassium voltage gated channels opening to reset the stage, only to do it all over again. Now studies have shown that it is this leakiness to sodium, but also that the cells become less leaky to potassium. Between that combination, potassium ions positively charged being trapped, and sodium allowed to leak in, positive charges. This accounts for the pre-potential that we see in all specialized cells. All of them have this action potential that I'm showing on the screen. All of them do. So my question to you is, why do you think the SA node is considered the pacemaker of the heart? If all of the specialized cells have the same type of action potential, Why is the pacemaker the pacemaker? And before I give you a clue, Alyssa, being always daring, go ahead. No, you're always the one that.
Does the SA node, is that the one that like sends it out so it determines when it should go?
That's true, but why is that the pacemaker? Why not the internodal pathways? Why not the AV node? And for that matter, why do we have ectopic pacemakers that you hear some people having that leads to arrhythmias, right? Now, in your field, do they call them dysrhythmias or arrhythmias? Because there is a more proper.
It's both.
Yeah. So dysrhythmias means abnormal patterns, but a lot of times in a clinical setting, they will use arrhythmias. Arrhythmia means there's no rhythm. That is the strictest definition of it. But people are going to interchange them. A means without, arrhythmia, right? Okay, so all of them have this action potential. All of them can reach threshold on their own. All of them can. Why not? Why not the Purkinje fibers? Why aren't they the pacemaker? And I'll give you a hint. Come on, this requires a little bit of math. Slope. Slope.
It's the highest position.
So the pacemaker, the SA node, has a steeper slope. It reaches threshold first. As you go away from the pacemaker, the internodal fibers, the AV node, the bundle of His, the right and left bundle, the Purkinje fibers, all of them progressively have a less steep slope.
So gravity has a large part to play into it.
Not gravity, it's just the permeability. They express different types of leak channels. They do. So let's say your SA node tanks. The internodal pathways tank. Which one would be next in charge?
Atrial ventricular.
AV node. Predict the heart rate in that patient. Lower because the slope isn't as steep, is it? Okay, they probably wouldn't have a lot of issues until they start doing something like heavy exercise. But they'll notice. They will notice. And that's why we can put a pacemaker in someone's heart. What if that gave out? Everything's out, and now we have just the right and left bundle branch. What would their heart rate be like? Even slower, wouldn't it? Slope is real gradual. What about if everything but the Purkinje fibers? The heart rate would be so slow, it would not be compatible with life. So it's the steepness of the slope. How permeable those channels are or not permeable. That is the reason why we have a chain of commands. Does that make sense? And that is also to follow on what Grace was saying, why you can detect that on an EKG. You can detect that on the EKG pattern for a conduction problem, which is what she was talking about earlier. Okay, you can. She was 100% correct. So again, all the specialized cells, all of them in this picture shown as in purple, have that pre-potential. The difference is the steepness. Who gets to threshold first? Because once the bullet fires, it spreads. It spreads. So as you go from SA node to internodal fibers to AV node to the bundle of His to the right and left bundle branch, Purkinje fibers, that steepness becomes more and more gradual, less slope, takes longer to reach threshold. Good? That is the molecular reason why we get syncytium. Atria together, then ventricles. with a delay between those two sets of chambers. It's beautiful, really, if you think about it. By the way, the specialized cells, they are not nerves. How many times have I said that today so far? Quite a few. This is the reason why we can give heart transplants to patients. We can. We can cut out Sophia's heart and give it to Don Julio. I'm just using you as an example. And we can put her heart into his chest and start it beating again, because then the pacemaker will take control once we give it the electrical, hey, you're plugged in now. We don't have time to reconnect sympathetic and parasympathetic fibers. That's like trying to connect two paintbrushes together. Once the nerves are cut, they're cut. So tell me, predict if you want to, if you can. If Don Julio had a heart transplant, compared to his resting heart rate now, what would his new resting heart rate be like, do you think?
Wouldn't that, like, depend on a couple of things?
Overall, in general.
Probably be slightly slower.
Nope. Okay, great. You could have gone either way, right? 50-50 chance. The truth is the SA node wants to go fast. Like me. I want to go fast. Last week, you all wanted to study for lab, and I was like, okay, fine. You were my parasympathetic fibers saying, Kara, come on, and let us study for a while. Let's slow it down. I'm like, okay, I still have enough time next week. It'll be okay. But the SA node wants to go. It's the parasympathetic fibers that slow it down. Change the permeability. Decrease the slope just a little bit. So if Don Julio has a heart transplant, his heart rate is going to be faster because there's no parasympathetic nerves connected. We can't, that's like paintbrushes trying to put them together. They will have a slightly elevated heart rate, and they need to be mindful of exercise, being excited during sympathetic moments. Remember, it's the 4 F's. Their heart rate will climb quite a bit, and it's going to take a while for them to come down from that. It's like an adrenaline rush. Okay? Okay. So that's just something to keep in mind. In your homework packet, I believe, I ask you to map out the events of the specialized cell's action potential. We have the pre-potential. What causes it? Less leaky potassium leak channels and more leaky sodium leak channels. The upstroke. Now the upstroke is different than what we saw in a neuron. The upstroke is actually from calcium channels opening. Calcium was never actively part of the action potential profile for neurons nor for skeletal muscle. It was not. And here we have the upstroke being caused by calcium channels opening. That means calcium is infiltrating the cell during the excitable event. And that means contraction is going to be quickly on the heels of it. Quickly! And I'm going to show that to you graphically. Not graphically, but graphically on the slide. And then our downstroke is, of course, our potassium voltage-gated channels, our good old friends that help repolarize. But again, the specialized cells are never at rest. They do not have a stable resting membrane potential. They do not. Now compare that to the orange profile that you're seeing. That is also in your homework packet. That is the action potential of a contractile cell. Please notice it does have a stable resting membrane potential. Please notice that it is much lower than that typical -70. Remember last semester I said resting membrane potential is -70, but that's just an average number. It's just a number. I need you to tell me why. it's negative. Remember that? I said, don't you dare give me a number. Don't you dare. And here we have excitable cells that can spike in action potential, just not on their own. And they have a resting membrane potential that is quite negative, close to 80, minus 80 millivolts. And then they have an upstroke. And then you can see there's a slight little repolarization. Then there's this plateau, and then repolarization. We're going to go through all 5 of those steps. Again, I see people in their homework packet. All 5 of those steps numbered 0 through 4. Don't blame me for that numbering system. We can hypothesize which gender came up with that. Anyway, 0 through 4. And to remind you from last semester again, that the heart is innervated. It is innervated by both the sympathetic and parasympathetic division. It is, for sure it is. But those nerves only influence the specialized cells. In particular, the parasympathetic division targets the SA node and AV node. The parasympathetic division can slow heart rate. It has little to no effect on the force of contraction. The sympathetic nervous system, however, innervates the SA node, AV node, and also the ventricles, which means they can increase heart rate and the force of contraction. In a clinical setting, when we're talking about heart rate, we talk about chronotropy. When we're talking about force of contraction, we talk about inotropy. And chronotropy comes first. Chronicle, time. If it's a sympathetic division, we use parentheses, and we'll say plus, comma, plus. Higher heart rate, positive chronotropy, and positive inotropy. How many questions have I answered so far? Quite a bit? Ladies over here are like, yep. If it's the parasympathetic division, again the parentheses, you'll see negative, meaning reduced heart rate, comma, and then usually a blank space because the parasympathetic division has little to no influence on the force of contraction. That's a good thing. Why does blood move? Pressure, okay, from to what? High to low. And what happens, do you think, to your heart rate when you fall asleep at night?
Dips.
It dips, it slows down. Now, what if, hypothetically speaking, the parasympathetic division, when it has more control, right? Because they're both, remember, I know your teacher, both systems are on all the time, aren't they? Nod your head.
Yes.
It's just a matter of which one has more control, remember? So at nighttime, which division has more control? Parasympathetic. Heart rate goes down. What would happen, though, while you're sound asleep if the parasympathetic division reduced the force of contraction? And before you answer that, how does blood flow again? And to get blood ejected from your ventricles, the ventricles have to contract with a greater force or pressure than what's out in the aorta. So any guesses? Go for it, Alyssa.
The pressure will just be less.
It would, and then blood flow to, through, and out of the heart would be
Stagnant.
compromised for sure, right? Absolutely. So that, thank goodness, parasympathetic has little to no influence on inotropy. Yes, Hulu, did you have a question? Now, in gray here, in both charts, you're seeing normal sinus rhythms, okay? You can see the steepness of that prepotential, the slope. And for the sympathetic division, look what happens to that prepotential slope. Can you see that? What happened to it?
It's a little before.
No, no, no. Here, look. It's reaching threshold faster, isn't it?
Okay.
Yes.
It is. We're even getting an extra beat here before we would have for a normal sinus rhythm. So someone who's nervous, scared, terrified, that's the reason why they have a higher heart rate. They have more sodium permeability, less potassium. They reach threshold faster. That's why. On a molecular reason, that's why your heart rate goes up. Look what happens to the prepotential when the parasympathetic division has more control. What happened to the slope? Is it steeper or less steep? Takes longer to reach threshold. That means reduced heart rate. We have 3 beats for the normal here, and we only see 2 when the parasympathetic is more in control. It changes, both divisions change the permeability. You want a faster heart rate, more sodium leakage, less potassium leakage. You want a slower heart rate, more potassium leakage, less sodium leakage. It's reversed. So here's that same video I showed you before, just different colors. Again, everything in yellow are your specialized cells. And I hope now you have another appreciation for the timing of these events. Timing is everything. Ray could not get out of this room. There were equal and opposite forces pressing on that door. Blood will only flow from one chamber to the next and out due to pressure changes. You want blood to go from the atrium to the ventricle, then the atria have to have a higher pressure than the ventricles. You want blood to go from the ventricles out to the aorta, if we're talking about the left side, then the left ventricle has to generate a greater pressure than the blood pressure in the aorta. And I'll remind you from our hemodynamics lecture and blood vessel lecture, all blood vessels have a blood pressure. They all do. But that pressure declines from one vessel type to another. Otherwise, you would not have blood flow from one vessel to the next, to the next, to the next, and back to the heart. So before I send you on a break, because it is almost time for you to have a break, let's get through a couple more slides. Here is the action potential profile of a contractile cell. It does have a stable resting membrane potential. It does. It has 5 different phases numbered 0 through 4. Phase 0, we have sodium voltage gated channels that open. And you might have read on my slides that I've described slow versus fast, and slow calcium. Don't worry about fast or slow. There are different, we were talking about earlier, different types of gene expression, okay? So sodium voltage gated channels open. There's our upstroke. And then they close for a while. And we get a slight little repolarization. But then we have calcium channels opening and potassium leak channels decreasing in their permeability. So we have this plateau phase right here, phase 2, where we have calcium coming into the cell. And even though the cell was trying to repolarize the calcium influx and potassium being trapped, we get this steady state. We get this plateau. And yet again, calcium is has an active role in the action potential. Skeletal muscle did not. Neurons did not. That is a very important distinction. And then for repolarization, our good old friend, potassium voltage gated channels. So again, here are the 5 phases. The upstroke is phase 0. Then we have the slight repolarization, that would be phase 1. The plateau phase where calcium starts coming into the cell, phase 2. Repolarization, phase 3, potassium voltage gated channels. And then resting membrane potential, phase 4. That's in your homework packet, for sure it is. So Ray, did that help?
Yes.
It did? Good. Up in the top pictures, you're seeing an action potential in skeletal muscle. And then this picture showing you the blue is showing you the force of contraction. In the light, whatever color you want to call that, gray, green, is called absolute refractory period. Did we or did we not talk about absolute refractory period? Did I or did I not maybe suggest a certain homework assignment? Do you remember that?
Sounds familiar.
Off camera, I'll remind you.
Oh, yes. I remember. Yes.
Is that now triggering anything? Do you remember? And in yellow, you're seeing relative refractory period. And you'll notice that the peak force of contraction in skeletal muscle happens after the cell, the fiber, has gone through absolute refractory and relative, and now it has its peak contractile force, which is why the forces can summate, which is why we can reach tetany. Do you remember that? There was a physio. You might want to revisit PhysioX number 2, just for kicks. But here is the action potential for a cardiocyte, a contractile cell. It doesn't just last milliseconds, short milliseconds, like 1 to 2. It lasts for close to 250 something. And right here, for phase 0, 1, 2, and part of 3, it's an absolute refractory period. Absolute, which means no action potential can be regenerated again. And look at the force of contraction. It is at its peak during this absolute refractory period, which means in normal physiologic conditions, cardiac muscle cannot summate, cannot reach tetany, which is good because why does blood flow again? Pressure changes from what to what? Good. So if these contractile cells in the atria or the ventricles are not in syncytium, that's Ray and I on the opposite sides of this door. No one's going anywhere. Blood is not flowing. And it's not until the force of contraction has gone down in relative refractory period where you could have another contraction. You will be doing a PhysioX for heart physiology that will show you that. You cannot reach tetany if a muscle is allowed to relax at all. The only way you can reach tetany, and I'll remind you if you did this PhysioX, remember you had to press on your mouse button over again? Okay. You can't let the muscle relax at all. And here we have a built-in safety mechanism. Can't reach tetany. So that's important because if your heart rate is about 70 beats per minute-ish, and a cardiac cycle lasts, a whole cycle with electrical and mechanical events, roughly 800 milliseconds. And only about 250 to 300 milliseconds of that is an electrical event and then a mechanical. That means a lot of time the heart is at rest. So what's happening when the heart is at rest? Number one, firstly, it's getting a well-deserved break. B, number 2, secondly, it fills. Blood returns to the atria, then pours into the ventricles. I'll talk about that in more detail after your break. And C, number 3, thirdly, during rest is the only time the heart myocardium gets perfused. I'll remind you, because you just had a lab exam on this, what are the first branches off of the ascending aorta? Nope. That's the first branch off the aortic arch. Off the ascending aorta, what are the first 2 branches? Right and left coronary artery. They're the ones bringing oxygen-rich and blood and nutrient-rich blood to the myocardium of the heart. It's the hardest working muscle you have. It beats roughly every time per second. It needs oxygen. It needs nutrients. Those are the first branches off. Grace was talking about ischemic issues. What if there's a clog in one of those 2 vessels? The only time that the blood flows to serve the heart is when it's at rest. That is the only time. Ray, do you have your sweatshirt on? With a hoodie? Yeah, I mean, I see you have yours, but it has a hoodie. Okay. So I'm going to use Ray as an example. And I'm wearing my hoodie too. Those semilunar valves are like the hoodie in our sweatshirts. They flatten when the heart is contracting and the blood is being ejected into the pulmonary trunk or aorta. When the heart is at rest, there is a momentary regurgitation, backwards flow of blood, and it fills those 3 cusps. Now, here's the rub. If we're talking about the aortic semilunar valve, when the heart contracts, the ventricles, the blood is ejected into the aorta. The semilunar valves are collapsed along the vessel wall. When the heart relaxes, there's a momentary regurgitation, backwards flow, and those cusps fill. There are 3 of them, so that valve is now closed. Blood cannot go backwards to the ventricle. But in 2 of those cusps are the openings to the right and left coronary arteries, which means the only time blood can flow is when the heart is at rest. The only time, let me say that again, the only time blood can flow to serve the heart is when the heart is at rest. So tell me, what happens when you exercise? What happens to your heart rate? It increases. And now your heart is working harder. Should it get more oxygen and more nutrients? It should. And yet, diastole, that's when the heart is at rest, shortens proportionally more than systole. That's when the heart is contracting. That means the heart is getting less time to rest, to fill, and be perfused. Arguably a reason not to work out. How many times have I said that in the last 2 semesters? You're like, we're not working out ever again. I'm kidding. When you work out, your heart gets a bigger myocardial mass. That's true, just like when you lift weights, your skeletal muscle will hypertrophy. But the heart remodels equally in width as it does in length, and it becomes more effective as a muscle, as a pump. And that means when you're not exercising, your heart can have more rest, more filling, more perfusion. Your heart rate goes down in between your workouts. You're more fit, but the heart is stronger as a muscle, So it still gets out the blood that it needs to get out. And the brain detects that. And if it could talk, it would say to the heart, "You are such a good heart. Oh my gosh, look at you. You're still matching the needs of this. Oh, take a rest." But if it's weak and there isn't getting enough blood ejected, then the brain says, "You lazy, lazy son of a gun. You're not getting enough blood out per stroke, so now you need to compensate by having a higher heart rate." Which is why people who are not physically active oftentimes have problems with hypertension and high heart rate. I know. On that note, take a break. Come back to me, please. We're going to do it all again and add some terminology, but a lot of the terms I'm going to go over again I have already used earlier in this lecture. Up here in purple, the top right of the right atrium, we see the SA node. And it shows it in purple because it is starting to reach that threshold. The prepotential is now causing the opening of the calcium voltage gated channels. That action potential spreads down, but also towards the left atrium. Take a moment to see the color spreading. And then if you look very carefully, you can see the atria contracting now. The electrical event precedes the mechanical. And you can see that the walls of the atria are kind of contracting, and they are pushing more blood down into the ventricles. We can see that the AV valves are open. Now the AV node is receiving that action potential. It's spreading it to the bundle of His, and it's now branching into the right and left bundle branch, which will go through the IV septum. So now the IV septum is depolarizing, having an action potential. It's going to spread around the ventricular walls through the Purkinje fibers. Now the ventricles are completely in their electrical event, and they're going to have a mechanical event. They will contract, and they will push blood up and out into the pulmonary trunk or aorta. But when they do that, we're going to see that blood will close the AV valves. That I need to expand on. We're going to go through it again. We're going to combine the electrical events with mechanical events. And even though we haven't done an EKG, I am still going to show you the parts of the EKG and what to expect, especially when it comes to the beast, which is a picture in your homework packet. And again, I'll explain what the beast is. For those of you who do see Caitlin, she'll even say, "Did Kara go over the beast? Did she go over the beast? Did she cover the beast?" She loves the beast.
She does get pretty excited.
Yeah, she does. She should teach. Mm-hmm. So take a moment just to look at the circle here, showing the cardiac cycle. Take a moment to see that a full cycle, which includes electrical and mechanical events, lasts about 800 milliseconds, just shy of 1 second. We have up here atrial systole. Systole means contraction. In order to have contraction, a mechanical event, you have to have an electrical event. We've covered that many times now. Then the atria go into resting mode, shown here in green, because now it's time for the ventricles to have their event. Again, blood will only move from high pressure to low. From one chamber to the next and out again, you have to have pressure changes. So during ventricular systole, the ventricles are having their moment to contract and eject blood into the pulmonary trunk and aorta. And then the heart is at rest for a brief moment called diastasis. That means all 4 chambers are in diastole. What is happening during this rest? The heart gets a well-deserved rest. The heart is being, it's filling. I'm going to talk about that. But more importantly, it's being perfused. So if I want you to consider atrial systole or atrial diastole, I have to add the adjective atrial. Most textbooks do not do that. They just say systole or diastole. If there is no adjective before those words saying if it's atrial or ventricular, you always assume they're referring to ventricular events. Why do you think the ventricles get this preference, even in the written language in textbooks? Why?
Probably because they're larger, they do more work.
They do more work, and they have to pump the blood out to the pulmonary circuit or systemic circuit. That's where most of the heavy pumping, heavy lifting, if you will, occurs. So I'm going to go through the cardiac cycle myself, and I want you to know that the events I'm going to describe are written here. You can always refer to them. And what I am going to refer to is mainly the left side of the heart. Why would I give more preference to the left side in my descriptions? It's similar to why I said the ventricles get more preference.
It's larger.
It's going to the systemic circuit, right? That's what Ray said. Okay. So the heart is in diastasis. Blood is returning to the right and left atrium. Blood is returning to the right atrium from the superior inferior vena cava and the coronary sinus. Blood is returning to the left atrium through the paired pulmonary veins. I will now shift to the left side. As the blood comes back to the atria, the blood pools in the atrium. The heart is still at rest. There is no electrical event. It's just at rest, getting a well-deserved break. The blood returns, and the atria start to fill. And because the pressure builds, the AV valves, like trap doors, swing open. You just swing open. And the blood will continue to go from the atrium to the ventricles. It will pour into the ventricles. That actually creates a heart sound. In most classes, your teacher will say there's only 2 heart sounds. Heart sound 1, heart sound 2, lub-dub. But actually, there are 4 heart sounds. There are 4. And the blood pouring into the ventricles from the atria. Again, the heart is still at rest. You're okay? So if I were to take this tea, pour it into a cup, would it make a sound?
Yes.
You've heard that. You've poured yourself a drink. It makes a sound. Of course it does. That is similar to heart sound 3, with the blood pouring straight from the atria down into the ventricles. It's just pouring straight down. It makes a sound. We have to use a special machine to hear it, but it's there. Now, the atria are now going to have their electrical event. And that means they're going to contract. And when they contract, they're going to push a little extra more blood down into the ventricles. Let me say that again another way. 80% of ventricular filling is passive. No action potential, no contraction, just pouring the blood flowing from high pressure to low. Passive. How can I explain that to you? 20% is active. Okay. So many of you do drive cars that require gas, yes? These days, still a lot of you do. Can you imagine if I'm still teaching, we're like, back in our day, we used to have to fill up our tank with gas. Eventually, give it some time, it'll change. So you're at the gas station, and you put the nozzle into your gas tank, and you lift the little lever, and you might use the little clip so that it holds it, and you can be hands-free pumping, right? You're not actively holding it. Sorry, I'm losing my voice already. That's passive filling. You're backing away. You might be on your phone, even though there's a sign that says thou shalt not be on your phone during this time. And then you hear the click, don't you? You go over to the nozzle again, the handle, and because you're like, my time is precious, even though, again, there's a sign that says thou shalt not top off your tank, you do. And you squeeze maybe a gallon or two more, right? And you love that because then your little gas gauge is like, oh, look at that, it's over F. It's over F. You love that, don't you? Mm-hmm. Never the opposite way. It's under E. That's never a good thing. No one celebrates that. So I want you to think about when you go over to the nozzle and you're pushing a little bit more gas, I want you to think, oh, I'm the atria contracting and I'm pushing just a little bit more blood into my tank, a little bit more gas into my tank. And with that squish comes more sound. Again, we need a special device to hear it, but that's heart sound 4 from the atrial contraction. So now that action potential has gone through the AV node with a little delay into the bundle of His with another delay, and now it's going through the right and left bundle branches, and it's spreading around the ventricular walls through the Purkinje fibers. And now it's time for the ventricles to have their turn. And they start to contract. That's a mechanical event. But they have a lot of blood that they have to push on, don't they? And let's review, anatomically, the ventricles are inferior. You have to defy gravity, especially now when you're sitting up or standing up, you have to defy gravity. So the ventricles really have to generate quite a good, forceful contraction. So Alyssa and Princess Jasmine and me, we have water bottles that we can squeeze on. Okay? When the ventricles contract, the blood rises superiorly. Can you see that? When the ventricles contract, the blood rises superiorly. And when the blood rises superiorly, it pushes underneath the AV valves. And as it pushes underneath the AV valves, they close. But the semilunar valves are still closed. And yet the ventricles are contracting. Can you hear that? Everything's closed, yet there's movement, isn't there? Turbulent flow. The blood has nowhere to go and is reverberating around and around in the ventricles. That is heart sound 1. And almost every professor I have ever watched says heart sound 1 is from the AV valves closing, which makes students think that the sound is actually caused from the flaps. Nope. They're endocardium. Soft. Why do we have sounds? I've said this to you even during the blood vessel lecture. We have sound because of turbulent flow. No one goes for a hike, remember this, and says, shh, do you hear the lake? But if you were lost on a hike, you would want to hear a stream or a river, turbulent flow. So then the ventricles generate so much pressure that the pressure inside the ventricles is now higher than the pressure of the blood already in the aorta. Again, I'm focusing on the left side. And how does blood flow again? High to low. And so now the pressure is so great, the blood is pushing up so much, it opens the semilunar valves. And blood is ejected into the aorta. And then the ventricles are having their electrical event called repolarization. And the mechanical event that follows that is relaxation. We forget about that. And the blood that was ejected into the aorta temporarily regurgitates, falls backwards. But it fills the cusps. So the blood swirls on top. And that creates heart sound 2. And most professors will say heart sound 2 is from the semilunar valves closing. It's not the valves. What is it? Turbulent blood. That's my class. Yes, good. So it's not the valves themselves. It's the blood regurgitating and then swirling on top of the closed valves. Because I'll remind you, when professors teach that way, heart sound 1 is from AV valves open or closing. Heart sound 2 is from semilunar valves closing. Then students think that only when the valves are closed, heart sounds are made. Turbulent blood is made, right? Didn't I just tell you that blood pouring from the atria into the ventricles, valves were open then, weren't they? Turbulent blood, reverberating, right? Pouring in, ventricles contracting, nowhere to go. Again, reverberating. That was heart sound 3 and 4. Okay, so it's not just valves closing. We can have heart sounds from open valves. Okay? Okay. So again, these slides are going through what I just told you in step-by-step fashion. And I want you to know that something I've been telling you all day long now, timing is everything. Blood will only flow from high pressure to low. You want blood to go to, through, and out of the heart. Timing is everything. Ray couldn't get out of the classroom because I was pushing on the other side. Systole, when the chambers are contracting. Do all 4 chambers contract at the same time? Is there a delay to let the atria have their event and then the vent? Of course. Where are the 2 places we have a delay? AV node and bundle of His. Systole, chambers contracting. There is an atrial diastole, an atrial systole, a ventricular diastole, a ventricular systole. And then when all 4 chambers are relaxed at the same time, we refer to that as diastasis. Diastasis. 3 important things are happening in diastasis. What are they? A number 1, firstly.
Rest.
Filling and perfusing. Good. Now, why is filling such an important thing? The heart, we forget, being like a lot of muscle, has some elasticity to it. It can stretch and it can recoil back to its original shape. So I really do adore Don Julio. But Don Julio, I have a slingshot right here, okay? I want you to hold the stick part of it. And I've got the pouch part, and I've got a big rock in it, okay? Hold it right there like that. The more I pull it, what's going to happen? More force. And usually right about now, the student goes, yeah. I'm like, so now Mariella's gonna get it in the face, the rock, right? But if I only pull it a little bit, what happens? Right? So you can let go. So the point is, the more filling, the more time the heart has to rest, the more blood can go pouring straight into the ventricles, the more it starts to sag like a water balloon that you might be filling up, or as I like to say, my grandma's breasts. It starts to sag. She's dead now, so I can say that. But the idea, okay, slingshot, right? More stretch, intrinsic property. What comes in must go out. If extra comes in, more goes out. That ensures that there isn't damming up of blood in the chambers, damming up of blood backwards into the pulmonary circuit or systemic circuit, leading to edema. We talked about that. Capillary hemodynamics, we did. So what comes in must go out. If it doesn't, we start seeing edema. These next slides go through everything I just said to you. Diastasis, AV valves open. Do you see that? Semilunar valves closed. We get heart sound 3 from the blood pouring into the ventricles, like you pouring a beverage into your cup. Then we would see the SA node and AV node firing their action potential, and the atria would contract. We would get even more blood going into the ventricles. That's the top off. That's you at the gas station. That would create more sound. And on an EKG, should you want me to give you that lecture at another time, you would see what's called the P wave. And most of the time, most nursing students, so P wave, that means the atria they're going to contract. An EKG looks dangerously close to an action potential. And I've heard a lot of clinicians describe an EKG as an action. No, it's not. It's not an action potential. It is absolutely not. Don't you dare ever say that to my face. It is vector analysis. It is a summation of vectors. And if you know that, then you know why the pen goes up and why the pen goes down. And even though Grace did say to us, of course, and she's right, that you can determine what's going on the EKG, that's true, 100% true. But there's a lot of power to know why the pen is going up and why it's going down. And that takes a lot of memorization away from that clinical aspect, if you know why. So the P wave, that is the atria having their electrical event, and it will be followed by their mechanical event. When the atria contract, we have heart sound 4. Now the ventricles get their action potential and they start to press on the blood inside, and the blood pressure is rising, and we see the AV valves closed, don't we? This is isovolumic contraction, which means iso means same volume. The ventricles are not having more blood added, nor have they ejected anything yet. Iso, same volume. All 4 valves are closed. And we get heart sound 1. Again, that blood is inside the ventricles swirling around. At this point, we would see on the EKG the QRS complex. And again, I'm happy to teach you that. The QRS complex is the electrical event for the ventricles before the mechanical event will occur. They're going to start contracting, and then eventually they contract so much that they have higher pressure and the semilunar valves will open. And we start to get ejection. When we start to get ejection, the amount of blood that's ejected is called stroke volume. And I'm going to tell you later on in the next 5 slides what end diastolic volume is, EDV, versus end systolic volume, ESV, and ejection fraction. Then the ventricles start to relax. They're repolarizing. That's their electrical event. We forget that repolarization is still an electrical event. And that precedes a mechanical event where the muscles relax. So as the ventricles relax, there is a momentary backwards flow of blood in the aorta or pulmonary trunk, and it closes those semilunar valves. Blood is swirling on top of those closed valves, and that's when we hear heart sound 2. Heart sound 1 and 2 have been called that, heart sound 1 and 2, because they're the sounds that you can hear without using a stethoscope. You can put your ear to someone's chest and hear the lub-dub, can't you? But heart sounds 3 and 4, even though they precede 1 and 2, have to be used with a special machine. Okay? So now we have diastasis all over again. We've come one full cardiac cycle. Here's the beast. You have a portion of this picture in your homework packet. The portion of this picture that you have is ventricular volume. The other parts shown here in red, and the parts here for sounds are important for you to know. And the part here shown in kind of the brown color are the events of the EKG. In your homework packet, these 2 lines here are labeled A and B. The next 2 very close parallel lines are labeled C and D. And then over here, this line is labeled E. And in your homework packet, I ask you to tell me an interval or a moment, a time when. If it's an interval, I need 2 or more letters. If it's a moment when, you give me 1 letter. And for the interest of time, so that you can start to practice that, I'm not going to go over that here. I want you to try and do that on your own, again, for the interest of time, so that you have time to work on this together as a class. But just to give you a heads up why, this line here is shown as letter E instead of this line. It's because it perfectly bisects the P wave when the atria are depolarizing. That's a good landmark. I do recommend that when you get your lecture exam that you draw in the pressure changes shown here in red, and that you draw in the EKG, and that you draw in when you hear the different heart sounds. Heart sound 4, by the way, would be somewhere over here when the atria contract after their electrical event. Again, a special machine we need to hear that. It's called a phonocardiogram. In red, it's ventricular pressures. Now, pressure and volume are inversely related. You are going to do a lab on that, a PhysioX. If pressure goes up, can't I squeeze out this tea and Mio drink? Volume would go down, wouldn't it? Pressure and volume are inversely related. If the ventricles are contracting at their maximum force, that's when your stroke volume is happening. That's where you're getting ejection of blood. Cardiac output is a flow. It is the amount of blood ejected per beat, that's stroke volume, times the heart rate. So heart rate times stroke volume, and you get approximately 4 to 6 liters per minute. We're going to pick 5, middle of the road. So that means your entire blood supply is going to, through, and out of your heart every minute. That's remarkable. Your cardiac output can go up if you're exercising. Of course it is. Why? Because your heart rate is going up. Do the math. For a well-trained athlete, it can go up to 35 liters per minute. Can you imagine that? The amount cardiac reserve, you see this woman on a treadmill. And we actually do a treadmill test. And the way the treadmill test works, quite simply put, is we put someone on a treadmill, we attach the electrodes for the EKG, and we start increasing the speed. And we see how long basically they can last before they start showing signs on the EKG that they're having rhythmic issues. And then we stop the machine. The more cardiac reserve you have means here's your baseline at rest, and we can push you really hard on the treadmill before you start showing issues. That's a lot of cardiac reserve. But if you're way down here, we barely push you on the treadmill, and you're already starting problems on your EKG, that means you don't have a lot of reserve. You are just sub-threshold away from having probably a heart attack. That's an issue. So definitions, real quick. End diastolic volume is the amount of blood in the ventricles at the end of their diastole, which means at the end of their resting period. That means they are maximally full. The tank is full and you've topped it off. It is roughly 120 milliliters. End systolic volume is 50 milliliters on average. Its name tells you at the end of systole, ventricular systole, there's only 50 milliliters left. How much was kicked out then? How much was ejected? 70. That's stroke volume. And an ejection fraction is just simple math. It's about 60%, close to 60%. We don't eject all of the 120. There's always some behind. That's reserve. Does the body need more blood ejected? Then it needs to ask for it. We talked about how we can have more blood flow to different tissues in the body. Remember active hyperemia? Shake your head, because I did lecture on that. And I mean shake your head this way, not this way. Because I was there. So cardiac output, heart rate times stroke volume. If heart rate is 70 and stroke volume is 70 milliliters per beat, that would be 70 times 70. That's about 4,900 milliliters per minute, rounded up, about 5 liters of blood going to, through, and out of your heart. And that's it.
I have a question.